Hi, my name's Janet Head, and on behalf of AHEC and the whole Student Government Association group that has contributed to this process, want to welcome you to our third program, this National Primary Care Week celebration. And I'm going to turn it over to these lovely club representatives, Kristen Lithgow, and let them introduce our speakers.
Got it. All right. Good job. Hi, everyone. My name's Kristen. I'm the president of the Internal Med Club here on campus, and I would just like to introduce Dr. Matt Hardy, who is a physician and internal medicine physician here in town at Northeast Regional Medical Center. He is also an assistant professor of internal medicine here. He's a 2007 graduate of KCOM, and he also completed his internship and his residency here. And he is also a residency program director at Northeast Regional as well. So we're very lucky to have him speaking here today.
Hi guys, I'm Sarah. I'm the president of NAPA, it's the Women's Physicians Organization on campus. And I'm just here to introduce Dr. Melody Stocks. She is a obstetrician and gynecologist here in Kirksville at Northeast Regional.
She's a 2001 graduate of Evangelical University in Springfield, Missouri, and a 2005 graduate of KCOM. And she completed her internship and residency at Mercy General Hospital in Muskegon, Michigan. And I'm Kathleen, I'm the president of the OB-GYN Club.
Where's you guys? I got you.
Okay. I promise not to talk about diarrhea today. Though, if you have any questions about it, feel free to ask. I'd be happy to. Again, I make myself available to you for the second years who've had to put up with me for the last several weeks. Well, they asked, Matt Hardy, nice to meet you all. I am an internal medicine physician here in town. I went to school here. I did my internship here. I did my residency here. And oh my gosh, guess what? I stayed here. I have tried to leave Kirksville multiple times. It is the black hole of my universe, and it sucks me back in every time. And there's a good reason for that. And they asked us to kind of give a little short spiel as to why we did what we did and kind of the path that we took. When I was in getting into medical school was in and of itself a challenge for me, just because I didn't make the decision to go to medical school until I was much further along in college. I was actually a music major when I originally went to high school or went to college. Wanted to be a band director. And when I got to medical school, the transition was a little bit difficult, getting used to the the amount of classes and those sorts of things. And so, you know, when I was trying to decide what I wanted to do, I knew I liked people, I knew I liked interacting with people, I knew I liked to teach, and I wanted to be involved in family medicine, I thought, and had a really strong interest in psychiatry. So actually, those were my two biggest interests leaving second year. Did my third and fourth year actually down in Rolla, Missouri. So I tried to get away, but I couldn't go too far. I just went down to Rolla. And during my third and fourth year down there, I had an absolutely fabulous experience in all my rotations. Most of the time people are saying, well, there's one that just definitely stood out. I hated, you know, internal medicine, I obviously hated peds, right? No, I really enjoyed peds. I really loved kids. I just didn't want to be their doctor. I had a tough time doing that. Some of the complications that happened in taking care of pediatrics in the hospital just did not appeal to me at all. So I kind of realized that that maybe wasn't the area I was most interested in. I still was interested in family medicine and psychiatry. I did quite a few rotations in family medicine. And I did quite a few rotations actually in psychiatry. I still very much am interested in psychiatry, but did not necessarily like just isolating myself to that. And with family medicine, again, it was that the pediatric component of it just didn't necessarily grab me the same way. At the meantime, again, medicine, I'm the black sheep of my family. Everybody else in my family is educators. I went to medical school, you know, shame on me. And so during my third and fourth year, I actually started doing some education. We really didn't have a didactic program. We had to kind of take that upon ourselves. And that's when I really started to get interested in long-term education for the purposes of specifically in the realm of medicine. And I did not know, because of my ignorance about the field of medicine in general, for a vast majority of my earlier career, was that I didn't even know what internal medicine was. I'd never heard of it. I didn't know that that type of a doctor existed. When I got down there, one of my third rotation was with internal medicine, and all I knew was that the guy was grumpy, he was always working, and that he was really hard on students. Yay. Okay, so I got involved in that, but he and I hit it off really well. And one of the great things I learned was that he utilized OMT on a daily basis in his clinic as an internal medicine physician. And OMT was one of the things that really drove me towards being a DO. We had great experiences in the hospital, got to experience his procedures. I did a lot of endoscopy with him, actually was able to get my hands on a scope pretty early on. I got to do a lot of procedures with him, and one of the things that kind of grabbed me was that he was the guy that if something was going on in the hospital and it was just everything was going wrong, the patient's blood pressure's dropping, they're breathing 40 times a minute, they're just not coping things very well, he was the guy that they ended up calling in. And he was able to come in and make a few adjustments, and inevitably that patient was doing better in a relatively short period of time. There was just something I saw about the depth of knowledge that he had in some of the critical care, the hospital standpoint, and from a procedural standpoint that really just grabbed me. And as a result of that, actually switched me very early on in my fourth year to make me think that, yeah, definitely I wanted to pursue internal medicine. When I started to decide where to actually go for internal medicine, it was kind of hard for me to decide. I had several different places that I had interviewed to and had actually some kind of semi-pre-acceptance. People were very positive about my interviews and those sorts of things, but ended up choosing Kirksville mainly because when I thought about where I wanted to practice, when I was trying to come up in my mind, what kind of a community do I want to exist in? How do I see myself functioning on a day-to-day basis? What kind of a job do I want? I decided to find a residency program that actually was in a community like that. So that would give me the opportunity to actually participate in the type of practice that I was going to do. And so that's part of the reason I chose internal medicine here. I got to do a lot of procedures. I do procedures over at the hospital every week. I do endoscopy, both EGD and colonoscopy. I also do bronchoscopy. I had the blessing to be able to work with a pulmonologist very, very closely, got my numbers for doing bronchoscopy. So I do bronchoscopy through the cords. And I've been a physician on my own here for the last 3 years, and it's been a blast. Over the course of the last 3 years, I've held a lot of different hats, because as soon as you say yes to one person, they make you want to say yes to a lot of other things too. I've had the blessing of teaching at KCUM. I started teaching the Principles of Medicine course as an intern, and I have just kept going with it because I really, really do enjoy doing that. Yeah, that's my story. So I'll turn it over to.
Right. I'm Melody Stocks, and I graduated from KCUM in 2005. I also did not decide on medicine specifically as a career until a little later on. I actually, leaving high school, wanted to be a midwife, which kind of goes along with what I do now. And childbirth kind of fascinated me, but my dad said that's not a real job, which is not true, but he couldn't find any in the phone book, so apparently it's not a real job. So I decided then I thought maybe I'll be a nurse, and then I can be a nurse midwife, which is an advanced practitioner nurse. And so then I thought, okay, well, I'll do that. And then I had a little change in my undergrad plans. I went to a small school instead of where I had planned to go. And the advisor's like, we don't have a nursing program here. Well, that kind of blows that out the window. So then I decided maybe I'll be a PA instead. So I went ahead and did my undergrad thinking that. And I wasn't until my senior year of college that I decided to go to medical school. So I got to take organic the first semester of my freshman year and the last semester of my senior year, which was really not cool. A lot easier the second time around, though. So then I applied to KCOM. I really didn't know what a DO was, and my dad actually said that wasn't a real job too at first, which was awesome. But he came with me to my interview here, and that totally changed his mind that yes, they are real doctors, and they do exist. And in fact, we had some in our town. So I really wanted to, I like the osteopathic philosophy of treating the whole person. And really, that's what drew me to osteopathic medicine. And then, you know, KCOM is the home of osteopathic medicine, so where better place to go? So this was my first place I interviewed and my first choice, and that's where I came. And while I was here, I thought I probably would do something with family medicine, but I really was still very interested in women's health. And I didn't know if I want to do family medicine with kind of an emphasis on OB and women's health, or do an OB/GYN residency. And through my clinical rotations, I thought I would hate surgery and hate ER, but I actually found I really liked surgery once I got in there. I really liked doing procedures. So that's pretty much what tipped my scales as far as doing family medicine. And actually, I don't like taking care of kids either. Love kids. I have 3 kids, but I don't like torturing them. I don't like their parents. I did not care for pediatrics. So in family medicine, you kind of get the whole 9 yards. And chronic disease is really not my thing either. I like, pregnancy, 10 months and it's done. We get a little chronic pelvic pain and those kind of things thrown in there. But for the most part, anything I have is you find out what the problem is, you fix the problem, you go on. So I kind of like that aspect of OB/GYN, but I could still be a primary care physician. We are considered primary care by a lot of insurance companies. Women can choose an OB/GYN as their primary care provider. That being said, as soon as they start developing hypertension, then as soon as they start developing high cholesterol that's not controlled with diet and exercise, I send them to internal medicine or family physician or somebody else. So my job as primary care, as far as I see it, is basically screening. I do a lot of screening, and that's really important to me. So basically prevention and screening. And then if we identify a problem, I usually send that out if it's not in my area. I tried looking for residency programs. Actually, I did the very same thing. Thought, what do I want to do? And I grew up in a town of 200 people. I graduated, my high school was in 1,400. It's very small communities. It came to Kirksville for med school. So I thought I probably would want to practice in a rural area. I actually have a National Health Corps scholarship, so I had to be a primary care doctor. I really didn't have a whole lot of choice in that either, if I didn't want to pay back the government like $500,000. So I kind of thought about what area I would go. Would I go more urban, inner city, more rural? So then I started looking at the programs, and my husband crossed everything off on the list he didn't want to live. So that's how we started our search for residency. And there's a lot of OB/GYN DO residencies, which I wanted to do a DO residency in Michigan. And my husband's from Ohio, and that's just not cool. So he did not. He's said, well, he crossed the entire state off. I'm like, no, you cannot do that. So I do not lie. He MapQuest from Ann Arbor, 100 miles from Ann Arbor, every spot, and marked the residency spot. He would not live within 100 miles of Ann Arbor because he's a big Ohio State fan, and that's where Michigan State is. So that's how I chose my residency side. No, really, I looked at numbers, things that were important to me, lower C-section rates, things like that, and then rotated at a couple of different places, all in Michigan, actually, and then settled in Muskegon. I was very happy there. I really enjoyed my residency experience. It was a community hospital, so a much larger community than Kirksville, but it was still a community hospital. We did not have a lot of the advanced specialties like maternal fetal medicine or GYN oncology. So it really was a place where you had to identify problems, triage problems, and then know when you need to refer out, which is what I felt I needed to know. Sometimes residents that are in a center that have a lot of the specialties, things get sent right to the specialist, so the resident doesn't really learn to triage those problems. What kind of workup do they need to do to stabilize the patient before they go to a larger center? And that was really important to me, and I think that I did accomplish that in my training. And then I had done my 3rd and 4th year rotations in Moberly, Missouri, which is not a site anymore for students, but at the time it was. And they actually qualified for the National Health Service Corps as far as their HPSA score. So I chose to go back to Moberly since I was familiar with the community. It did qualify for my scholarship, and my husband still had a job, the same job he had through medical school and stuff he kept. And he actually still works there. So that's how we kind of made that decision. And then the opportunity opened up in Kirksville, which we had always really enjoyed this community, and he did not want to live where he worked, which is opposite of probably anyone else. But he's a child abuse and adolescent counselor, and he was a little in conflict with our kids in the same school as his clients and wanting to know, Daddy, why do you know them, and stuff like that. So we kind of separated our personal life from his job, and that's actually the main motivator for our move. But I joined with Dr. Speak with the Health Council. I love the Health Council. It's a federally qualified health center, which means we do sliding scale, which is right up my alley, giving low-cost care to people that can't afford it and make sure they get good quality care. So I've been very happy here so far. I've been here about 6 weeks. And I do like to teach, and I will take students.
I was also, interestingly, she said she was a National Health Service Corps. I also had a primary resource loan through the state of Missouri, actually. The Primary Resource Initiative of Missouri is a PRIMO. I don't think actually that program exists anymore, but that was something that I also did. So from a rural standpoint, it was an opportunity. I knew that I was going to be in a rural community anyway, so it ended up working out very well for me. Yeah, let's go ahead and just open it up for some questions. Oh, come on. I told them that you were good at asking questions. You certainly grilled me this morning. Yeah.
Hey, Dr. Hardy. I guess maybe if you can just talk about some of what you see as the good and not so good of being internal medicine versus some other, choice in terms of your career path.
Well, as one of the doctors that I really took as a mentor kind of said to me, you really just can't beat an internal medicine residency because it's a stepping stone to a lot of things. If you want to do primary care, you have the opportunity to be a primary care physician and be in the clinic predominantly. If you want to go into hospital-based medicine, you want to do more of that critical kind of care, you can do that. You can do a mixed kind of a picture where you're doing inpatient, outpatient. You can go do a subspecialty, and there's plethora of subspecialties that are available to you in that. I think the biggest disadvantages to internal medicine are that there's been a very big push away from general internal medicine. General internal medicine is kind of falling away from like what I do to being more the hospitalist and doing more the subspecialty. So if you are more interested, not to say that you can't, I mean obviously there's lots of programs available, but I think a lot of internal medicine is kind of pushing in that direction. I'm a big advocate of doing the primary care route. The things we don't do a lot of surgery, we don't do a lot of procedures. I had to fight to get the procedures that I have because I'm competing with gastroenterology, I'm competing with pulmonology, I'm competing with general surgery. So I have to work hard to get those numbers and to make sure that I maintain my, my ability to do that. And that's a little bit of a tough part of my job. Obviously, if you're interested in pediatrics, mine's the wrong field. Okay, in general, we don't see pediatrics. Now, if you do a subspecialty, you will see pediatrics because there is not that many pediatric gastroenterologists or pediatric rheumatologists. If you're a rheumatologist, you're going to end up seeing that entire spectrum. But and then if you want to deliver babies, in general, most internal medicine doctors avoid that like the plague. So I would pick a different field. But personally, I think there's no better residency than internal medicine. So there you go. Yeah.
Yeah, I have a question for OB. A lot of people, like older doctors, tell them that you're interested in going into OB, they'll be like, you're going to take that because on-call is terrible. And so I was just wondering how you.
Yeah, I got the same thing all the time. Why are you doing this? Like, it's a horrible lifestyle. And, well, first of all, residency is way worse than being attending. So if you can make it through an OBGYN residency, which should be getting easier with the work hour rules, I would assume, they can't keep you up for 30-something hours in a row, then you can make that lifestyle transition. A lot of OBGYNs have chosen to go in with big groups, which I haven't personally. Some of the large groups, though, only take call a few times a month, so it's really not that bad. At the same time, you won't necessarily deliver your patient, so you have to kind of, it's important to me, that's part of primary care, is taking care of your patient through the entire process. So we don't have really large numbers here, which allows us to do a lot of our own calls. So Dr. Speak and I both do our own call during the week. And before I came, they were doing all their own call every single weekend, which I thought was insane. But we actually alternate weekends. So last weekend, I don't know which one of us was on call now because I can't remember. I was on call last weekend. And so this weekend I'll be off. I'll still be in town. I'm not going anywhere, but at least it allows you to separate from your space. But I think that a lot of the older physicians, that when they didn't have work hour laws, I mean, those rules have made a big difference in attitude, I think, in some ways, although they all think that we should work like a dog and die doing it.
In general, and Melody, please correct me if this is false, but you create the practice that you want to have. Okay, from a training standpoint, yeah, training's tough. Training's tough in no matter whatever residency you're going to do. And even with the work hour rules being the way that they are, yes, there's the benefit of you're not at work as much, but you lose out on some other things. You may miss out on some continuity. You may miss out on procedures when you're talking about surgeries or otherwise. But when you're out, when you're the physician, when you're the one making those decisions, you're the one who's going to decide what kind of a practice you want. If you want to work part-time, you can work part-time. If you want to work full-time, you can work full-time. If you want to work with a big group, then you can work with a big group. If you want to be individual, you can do that. It's a matter of what you want. And understand that there's benefits and there's negative things about everything. Mm-hmm. Big group, you lose continuity, but you don't have to take as much call. So which one's more important to you? And there's nothing wrong with picking either way.
In a big group, when you're on call, you're slammed because you're taking 15 doctors' patients. When I'm on call, I may not even have a call during the week because I'm just taking care of just my patients. So there's a give and take. There's also, a lot of people don't realize that you can be essentially a hospitalist as an OBGYN, a laborist. A lot of the larger hospitals are going that way. So the big groups, sometimes they don't even deliver their own patients. There's just an OBGYN in the hospital that delivers babies. They take 12-hour shifts. You do your shift and go home like an ER doctor or something like that. So really you can make it what you want.
Yeah.
Kind of building off that question, what you guys said, especially for you, is it hard having a family then? Like you said, you have 3 kids. Like, does it ever get in the way of your family life? Do you ever regret being like you get pulled away from a dance recital? I don't know, something like that.
It hasn't happened very often. When my kids have activities, usually even if I'm on call, like Monday night we went to meet some friends in Macon, so I just called Dr. Speak and say, hey, can you cover for me for 3 hours? And he said yes, and nothing happened during the 3 hours. So even, and in Moberly our call was a little different. We did share each other, it was 2 of us, so we shared each other's call. It wasn't a whole lot different, but we shared call. And the same thing, if I was on call but I needed off for a few hours for my daughter's birthday party, for instance, on a weekend, that happened 2 years in a row, I just asked her, I said, can you cover me for a few hours? And it hasn't been a problem so far. I mean, do I miss some things? Sure, but you have to kind of give and take. I mean, there's some things you'll miss. And then I do a lot. If a patient in labor, you don't necessarily, depending on their risk, have to be at the hospital right then. So a lot of times what I'll do is try to get my kids in bed, read them the bedtime story, and then go to the hospital. Try to make the time that I have with my kids matter while I'm there. But yeah, you'll miss stuff. I mean, I think I've missed probably every one of those first steps, just such as you will. If you work, anybody that works, they're going to miss things.
It's a balance. I mean, with anything, even in my particular field by the time I get home of an evening, because I do a lot of other extracurricular stuff outside of even my own job, I make it a point to spend time with my son. I make it a point to read him his bedtime story, make sure to tuck him in, those sorts of things. And then after that, go back and do what work I need to do for the rest of the day. So, it's a priority thing, but it's also a give and take, exactly like she said. Yeah.
Kind of along those same lines, as a woman, when did you find out, like, when you could start a family, when was the time to start a family, kind of balance that?
Is there ever a good time to start a family?
Ever. Never a good time to start. So you just, what's right. Actually, I don't think that's necessarily entirely true. I had my first baby in November of my 4th year. So I kind of already decided what I want to do. A lot of the major things out of the way. The baby was here before I had to take any major exams were done. I mean, I threw up a lot during my complex too. But yeah, don't eat Egg McMuffins and orange juice before your board tests ever. So there's not necessarily a great time, but that worked for me. And I had the time off I kind of saved up so I could take 4 weeks off. We worked out that it happened during the holiday season, so I could get off for Christmas and still be off for maternity leave. And then as a resident, generally your intern year is probably never a good time to have a baby.
Which is when I had, well, I didn't.
Well, yeah, you physically did.
You can find me in Time. Thank you.
Yes.
Check it out.
So as myself, I don't think that most female physicians, your internship, especially if you're going someplace that you've never been before, it's a whole new transition. And that was a very hard year, moving to an entire state that I've never been to and a city I've never been to and doing something I've never done that's very rigorous and you're trying to learn what all your attending's like, and it was very stressful. So my next one we had during second year, which was a nice transition time, and I kind of tried to avoid the fourth year. I joined a physician in Moberly when I started was planning on retiring. So I asked him one of my first days there. I started on September 15th. I said, so is there a good time for me to have another baby? Because we want another kid and we don't want them too far apart. And he's like, well, about a year out. If you have your baby about a year out, that should be about right. So I got pregnant. My due date was September 16th, my second year. Just the day after my first day. I delivered a month early. And actually, that was tough. I mean, I'm not sure that was actually very good advice, just because I had a good 9-10 months of building a practice, and then I had my baby and I was off 6 weeks, and whoops, there go my patients. I mean, really, that was probably not really great advice. Probably the second or third year in would have been better as far as having an established practice where my patients are loyal to me and have met me, and because I lost quite a bit there. It was a hard comeback. I don't know how you're paid, but I was paid on productivity at that point in time, so taking 6 weeks off and losing patients, I mean, kind of killed productivity for at least 4 months after that.
Yeah, and yeah, in general, when you're starting a practice, no matter what field you're going to go into, it does take a good 2 years to really get something established. I mean, for the first year, you're really just trying to talk people into believing you, and I don't look like I'm really old, so I have a lot of older patients who look at me and say, seriously? And yeah, getting them to buy into it got to be a little bit tough. By the end of the first year, I definitely had patients who were coming back to see me purposely. You know, they weren't being conned into it. And then by the time, you know, my second year ended, like now I have a very steady practice, and so it does take a little while. Yeah?
Do you see patients in the hospital too?
I don't. That is one of those things that really I had to give up, and I missed that. When I did my residency here, really, we train people to be very good in the hospital. We don't spend a ton of time as an outpatient. Now, because I owed the state of Missouri as a primary physician, they did not consider hospitalist medicine to be primary care. So I chose to do outpatient as a direct result of that, and actually had a contract with a different hospital. And my buddy was there. We were gonna have a practice there. We were gonna start an internal medicine residency. We had this whole thing kind of mapped out and planned out. And then he called me on the phone and he said, "Matt, I know you're a strong family guy. I worry about your marriage if you come here." No kidding. Best friend in the world, right? He said that he was working 14 to 16 hours a day because he was doing both inpatient and outpatient. And what was actually happening was he was going in the morning, right around 6 o'clock, so he could round on a couple patients that were old, so he could go do maybe a stress test or two. Then he would go to the office, see about 20 patients in the office. After the end of the day, go to the hospital again, see his admits, and hopefully finish out whatever he hadn't done. And if that's not that uncommon, I mean, that's how it used to be. The problem was that there were about 10 family medicine doctors who didn't want to see patients in the hospital. So they would admit their patients under him. So he was doing a hospitalist practice in addition to his practice. And that was too much for him. And so when I ended up stepping back and trying to decide, okay, got out of that contract, one of the hardest conversations I've ever had, but I got out of that contract and was looking at different places to go. One of the driving forces actually for me staying here was KCUM and getting to teach. And to stay here, I could not do inpatient because they would prefer me to do with the hospitalist. So I gave that up. In retrospect, like now, I'm okay with that. I love what I do. I love the fact I don't have time to do anything else anyway. I do everything. I teach over here. I'm program director for the IM NMM dual residency program. And I'm medical director for several different groups here in town. So I'm able to do what I want to do. Sometimes I miss that. And I've worked in the ER on occasion, and that kind of helps me go in and do a little bit, and then I get tired of it again, so I walk out. Yeah.
Dr. Stock, how much time do you spend at the hospital versus kind of being in clinic with a patient? How does that work?
I spend a lot more time in the clinic than like a general surgeon would. I generally have a half a day of surgery a week, and then I'll see patients. I usually round, it just depends. If the patient's not going to be there and not going home, I'll round at noon over lunch. If they're going home that day, I like to round in the morning so they're free to go. And then I usually see any new admissions in the evening, so if I've put them in. And then the way I do my practice is that if I have a patient in labor, I still see patients. I basically just go back and forth. We have telemetry monitoring. I can watch the monitor in the office. And the nurses are used to not having the OB/GYN right there. I think they'd probably freak out if we were there
And
all
her
the time.
clinic is really close
It's
to it,
very
too.
close, yeah. So I just run back and forth when needed. And so I spend most of my time. And with the National Health Service Corps, I'm required to spend, with the OB/GYN, it's a little different than others, but I think we have to spend at least like 26 hours in the hospital, plus 8 hours you can have as administrative time, but you still have to be primarily office-based. They give us a little time for delivering babies because obviously that's part of it, but we still have to be primarily office-based. And you don't get patients unless you're in your office. I mean, the money comes with the procedures, but you don't get procedures unless you're in the office seeing patients. So.
How much O&M are you incorporating into your practice?
Well, you can incorporate however much you want to, basically. Personally, I do some O&M on my pregnant patients and occasionally a pelvic pain patient here or there. I would say I may do O&M 5 or 6 times a week, which is not necessarily, maybe once a day, sometimes twice a day. It just depends on how busy I am and what I'm doing. So not nearly as much. I didn't have a lot of O&M during my residency at all. And you really, if you aren't using it all the time, you just get, one, your skills aren't nearly as good, and 2, your confidence level in your skills is pretty pathetic, at least mine is. So, and we had an O&M department that did all of our consults when we were residents, and we had O&M residents, so it was like, we didn't do it, we consulted them, and I can do that again now. But in Moberly, we didn't have that option, so if the patient needed O&M, I had to do it. I mean, that was just how it was, and I would if I felt like it helped. But a lot of pregnant women have a lot of rib complaints, low back pain, those kind of things. So, and I think it helps. I usually do things that I can teach them to do, and stretches and things like that they can do at home, because that's going to really give them the more long-term help, basically, that they need.
Yeah.
I guess same question for you now. How often do you use O&M very often?
I use OMT. One of my goals in my office is to integrate OMT into every patient, if I can do that. Okay. When we started looking at doing the dual residency program, the IM-NMM, the big question was what's going to be the benefit of doing that versus, say, just doing a +1 OMM on top of an IM residency. And where I think that comes down to is when you do have a clinical scenario, the question always has to be asked from an OMM standpoint, what other things do we need to incorporate? You use it every day when you do a physical exam. I mean, anytime you put your hands on a patient, you're using your OMM skills, because I guarantee from a palpation standpoint, your ability to feel things is 10 times better than people who haven't done OMT. And so just to feel or to percuss the chest and to do those various different things. Also I'm not an orthopedist by any stretch of the imagination, but I can examine a joint. And it's amazing to me when I've gone and worked with other groups that they have no idea. They've got knee pain, send them to ortho. It's like, well, what if it's just, something else? Or we had a patient came in who actually came in with knee pain from the hospital. And she said it's been hurting her. They gave her Norco. They did some other stuff on her. And when she came into the office, the big question is, where does it hurt? And when we finally found out, it was actually her patellar tendon. We found out she'd been put on Cipro as a result for a skin infection. So she's on a fluoroquinolone, and those people are at risk of having tendon ruptures. And sure enough, that's probably what was in. We stopped the Cipro. She ended up getting better pretty quick. So it's, it's stuff like that you should be using it every day. And in internal medicine, it's a lot easier to do that because it's just part of what we do. And I have patients specifically who come in for OMT. And if you're coming into my office for OMT, you need to schedule it that way. I'll do like one thing or two things with a patient, and it helps from a billing standpoint. But if you want to be treated, I set aside more time because that's the biggest factor when it comes to doing it. Yeah.
You guys have talked a few times about different billing issues, different money, just in general. Did you guys find it really difficult to set up the business side, and what did you do to kind of figure that out?
Well, I didn't set up the business side. I walked into something. That was a good idea for me. I don't have a business background, so I'm employed. I'm employed through the hospital. Okay, I receive a salary, and I justify my salary by what I do. Okay, and I'm held accountable to that. So when you start talking about, what kind of a practice you want to develop, what kind of you want, if you want to be in solo practice, then it is on your shoulders to make those decisions. If you want to be employed, you don't have to make those decisions, but you give up some freedom because you're held accountable to that.
Yeah. Most OBGYNs are not in private practice anymore because it's very expensive with our malpractice insurance. So I was employed. CHS owns the hospital here. They own the hospital in Moberly. So I was employed by CHS. And I had what's called an RVU-based contract. It's a relative value units, and that is basically CMS or Medicare or Medicaid assign so many points to a patient visit, whatever level patient visit. And then however many patients you see, they add up those points and see if you did the work that they thought you should do to get the salary that they're giving you. And then you get, my contract before was basically if I don't meet it, I get my salaries cut. If I do meet it, I get a bonus. So essentially you're still paid by what you do. But I was also employed, and then now I'm employed through the Health Council, which is a little different because I'm not employed by the hospital that I'm working at. So it's a little different, but the Health Council still bills everything, and essentially it's the same type of contract there. I have a salary that as long as I meet my work RVUs that I'm assigned to, here it's quarterly, there it was annually. And there's national numbers that say an OBGYN should do this many work RVUs a year, so they use those numbers to base. For some reason, at the Health Council, I have to do 60% of average, which is not really fair because it's more than average. But so the 60th percentile, basically. But anyway, but I don't get a salary cut if I don't make it there where I did at my other job. I just get bonuses instead of, which is nice because salary cut really stinks.
Yes, it does.
Yes, it does.
Billing is not something it's not something that is easy to teach, and that's part of the reason why it's not really taught, because it changes all the time. So how you actually get it done is.
But it is important because your office codes, like if you bill whatever office code you bill, is going to be worth more, and that in the end does affect your numbers. I mean,
absolutely.
It does make a difference, and it is important, but it is very hard.
We have a 99, like my two biggest codes are 99213 and 99214. Those are a level 3 and a level 4 office visit, and the difference in the price of those is significant. And most of the time, in an internal medicine office, I do a level 4 visit almost all the time just because of the complexity of the patient. But most internal medicine physicians bill level 3s, so they're not actually billing appropriately. And that can make a big difference from a financial standpoint.
You guys will have it easy though, because your EMR will tell you what to bill.
Yeah?
Are there things that either of you would do any differently or recommend that students do a certain way?
Well, there is one thing I probably would have done differently in my career. I don't regret the path I took to get where I'm at by any stretch of the imagination, because I'm very, very happy to be a physician. I'm very happy to be doing what I'm doing. Okay, if you need somebody to say, no, it's worth it in the end, yeah, come talk to me. I love what I do. One thing I think I did realize was that when I started my internship, I was behind. I was quite a bit behind. And that's because I didn't have much of a house staff to help me as a 3rd and 4th year student to help teach. If I could have done it again and knew I was going to do internal medicine, I probably would have done my 3rd and 4th year in a bigger institution that did have a lot of the subspecialties, so that I would have a better grasp, a very strong didactic background, and I still would have done my residency where I did it, in a smaller community, because that's where I was going to practice. But as a student, that then lets you have maybe a little bit stronger knowledge base. I think that's the only thing I would have. I mean, I'm really happy with where I'm at right now.
I think I would say the same thing, because I went to Moberly, so they didn't obviously have a lot of subspecialists. The good thing about the small hospitals, you get to do a lot of things. Like,
You really do.
he would never get to put his hands on a scope in a big institution. That just would not happen. Half the time, this resident won't get to put their hands on the scope. So that's the nice thing about a small hospital, is you get to do that. It is good to at least do out rotations at big hospitals just to get an idea of what the flow is like. And then I would probably have not done quite as much OBGYN. I did partly just because I wanted the experience, and that was good. It did help in the end, but you will learn that in your residency. So probably if I'd had the opportunity, which I try to do, a derm rotation, some of those things that are very helpful, but you're not going to get it. I got no dermatology in residency. We're OBGYNs. I can tell you like pregnancy associated rashes, and that's about it. And internal medicine is very important. I mean, that was key, I think, for me, both in as an intern. So probably hitting maybe some of the specialties as resident, a cardiology rotation, things that really down the road that you have a clue.
Yeah,
So,
cardiology,
helps.
pulmonology rotations are very helpful.
Yeah, I would definitely
No
try
matter
to
what
do
you
that.
Yeah.
People maybe looking into these 2 specialties, could you maybe go a little more into that 4th year, some things that maybe to prepare for the interviews, what audition locations would you consider doing? I mean, if you want do internal med with radiology or an endocrine rotation in the hospital, would that be something that?
I counsel a lot of, so the question is, what kind of stuff might you do during 4th year to kind of prepare for the interview process and making a decision to transition into residency? I counsel a lot of students, because I have people come to my office quite a bit to actually ask me that question, and it's not a short answer. Because there's a lot of factors that have to be taken into consideration, and there really isn't to me, a great way to approach it. If you know you want to go somewhere, or you think you might want to go somewhere, it pays to go there. Okay? If they've seen you, you stand a much better chance of getting in. Okay? So that's one thing. But I mean, when you start thinking about, okay, I'm really interested in internal medicine, but I'm thinking about maybe cardiology. Is Kirksville a good site for me? Well, yes, from the internal medicine side of things, but if you're interested in doing cardiology, you might look at a program that has both, because then you're able to get yourself seen by both groups, or you're able to be a part of those didactic sessions and those sorts of things. That being said, even here in Kirksville, we have had lots of people go on and do fellowships. We've had several do critical care fellowships. We've had oncology, we've had cardiology, we've had GI. So it's definitely possible to do that from anywhere, but yeah, I mean, it's a tough conversation to have, or tough decision to make. But ultimately, if you know you want to, or you think you want to go somewhere, it really pays to go there for rotation.
I agree. I went where I thought, by the end of my 3rd year, I was pretty set as far as the programs that I was going to look at, and that's where I made rotation plans there. And while I was there, even though they weren't interviewing, it was the summer, I said I want to interview while I'm here if possible. They knew that my interest level was very high. I was one of the first people interviewed, so I didn't have any competition yet. And then when I actually did do my internship there, it was a world of difference when you already know some of the nurses' names, you know what the flow is like. So I think it made a big difference, just being aware of what I wanted to do, where I wanted to go. So.
And that's not easy, because I didn't know I really wanted to do internal medicine until I was in my 4th year, so.
That'd be really hard.
Yeah, it was tough. Any other questions? Yeah.
So how many audition rotations did you do?
Essentially 2. I went to Lansing and I went to Muskegon, and Grand Rapids is right in the middle, and that was my kind of other choice. So I actually called them while I was there and said, hey, can I have a tour and possibly interview while I'm up in Michigan? And that was all very early. I went June and August to those 2 sites, so it was pretty early on. And actually it worked out really well for me, both places. So
I did 3. I went to De Pere, I went to Joplin, and I went up to Grand Blanc in Michigan to Genesis Hospital. And notice none of those are Kirksville. Yeah, I did those 3 and basically did the same sort of deal. Just made it very obvious that I was very interested in their program, that I wanted to know more about it, that I was willing to do whatever to talk to people, to do a little bit more. As a student, you're not actually held to work hour rules. You can use that in your favor.
work
If
a
you
lot.
want to, it's worth it in the long run, because you don't have work hour rules, meaning you can stay at the hospital 100 hours.
And I did.
So if you really want a spot, you can make yourself known.
Yeah, I did. And also just be on the other side of it, when we were choosing candidates to come into the residency, they are just, at least we were just as nervous about filling our spots as people getting spots.
Yeah.
So being just that interested in a spot, that's where I want to go. I really like your spot. It puts them at so much more ease. If we get to rank this person 1, we know we're going to get them, because they're just as concerned about filling their spots as you are in getting one.
Yeah, that's true. That's absolutely true.
We have a little thank you for each of you, and
It's not full of money, sorry.
Oh,
Really appreciate it.
Pens
thank
are
you
good.
very much.
we've certainly hoped that the opportunity to really have an extended Q&A time with all 4 of the physicians that we've had this week has been helpful to you. Hope you'll follow up with them later, and let's give them a thank you now.